Hello everyone. In this particular video we would be going through obstetrics. So you might see some changes in this particular setup. So first of all, there is no camera over here, so you can't see my face. I know it is very sad, but due to this one, computing issues, I won't be able to add camera anymore. The last time you might have seen the part 7 of pediatrics. The reason why it was uploaded separately was because I had to re-record the entire thing. So I don't want to experience something like that ever again. So that is the reason I am doing this without camera feed. And now we have obstetrics. So obstetrics, we would be starting from the third chapter, because the third chapter is from the third chapter the important questions begin. And now coming to the first one, which is functions of placenta. So placenta plays a vital role in supporting fetal growth and maintaining pregnancy. So we all know how placenta looks like. During delivery it is delivered, and it is an important anatomical structure. Its functions can be broadly classified into these: transfer functions, endocrine functions, barrier functions, and immunological functions. So coming to transfer functions, so in this particular case, placenta facilitates exchange of nutrients, gases and waste products between the maternal and the fetal side. So this includes various sub functions. So what is getting transferred? So mainly gases over here. So oxygen, carbon dioxide are being exchanged between maternal and fetal circulation via simple diffusion across the placental membrane. So there is the placental membrane, and from one side there is, on the fetal side there is less of oxygen. So where there is more of oxygen? On the maternal side, so it will get on this side very easily. But carbon dioxide is more on the fetal side and less on the on the maternal side, so it gets transferred very easily, and there is no ATP required. And since this one is non-ionic, and ions specifically non-ionic, it can get transported through the hydrophobic membrane. We don't specifically need any kind of proteins, so that is why it is simple diffusion. Coming to the oxygen supply, the oxygen supply is it is 8 ml per kg per minute, achieved through cord blood flow of 165 to 330 ml per minute. Excretory function: waste products like urea, uric acid and creatinine are excreted into the maternal blood via simple diffusion. So this fetus, as it metabolizes various things, like in case of proteins it gives rise to urea, in case of the DNA and other nucleotides and all that, it gives rise to uric acid, and in case of creatine it gives rise to creatinine. So these are excreted. So these are a lot in quantity, on the meaning concentration wise. The fetus, though it is very small, the concentration like per ml, it is very high in the fetal side. So these things get transferred very easily into the maternal blood through simple diffusion, again because it is mainly dependent on the concentration gradient. So more of it on fetal side, so more concentration of it on the fetal side, so it goes into the maternal side. Next, coming to nutritive function. The fetus derives nutrients from maternal blood. So when maternal dietary intake is insufficient, fetal nutrient supply depends on maternal stores. So in this particular case, if you imagine it, the fetus behaves just like a parasite. Next, coming to mechanisms of substance transfer. So we have various mechanisms involved, and we have already seen simple diffusion in case of oxygen and carbon dioxide. It is mainly dependent on concentration and electrical gradients. So if something is less on one side and more on the other side, it gets transferred very easily. So that is the basic principle of simple diffusion, which we have all studied in class 12th and 11th. Coming to bulk flow and solvent drag, movement of water and dissolved solute driven by hydrostatic and osmotic pressure. So this thing has been I won't go into the details, but this is mostly the principle of so many drugs and all of that. So mannitol, and also the renal side, so many things depend on this. Not just this, so many of these we have we can apply the same thing over so many sections. Next, coming to the facilitated diffusion, transporter proteins mediate the movement of glucose and amino acids. So, mediator proteins are involved in transport of certain things like glucose and amino acids. Active transport, energy dependent transfer of amino acids, large ions and certain vitamins. So, it happens against the gradient. So, whenever it is against the gradient, what do we need? We need energy. And which are the substrates? Amino acids, large ions and certain vitamins. Coming to endocytosis, which is also known as penocytosis. Cellular engulfment of extracellular molecules like immunoglobulins. So, even that forms a transfer mechanism. Also exocytosis. So, these two are similar in nature and can be clubbed together. Release of molecules from vesicles into extracellular space. So, eating up and releasing, meaning this is drinking up and releasing. Leakage occurs when there is a break in placental barrier leading to fetal red blood cells entering the maternal circulation. So, even this one forms a transfer mechanism. So, overall, what are the things that are being transported? So, we have learned the mechanisms. Now, coming to the means of transport, meaning the key things that are being transported. The first one is glucose. Principal energy stores transferred via facilitated diffusion. So, there is GLUT1 transporter which is involved in facilitated diffusion of, meaning without energy of transport of glucose. Glucose transfer is non-linear and decreases as maternal glucose levels rise. So, whenever maternal glucose levels rise, the glucose transfer decreases. So, it does not follow proper linear growth. So, whenever you have more of maternal glucose, the fetal glucose being high, no, that is not the case. It is a non-linear graph. Next, coming to lipids, triglycerides and fatty acids are transferred across the membrane. So, did we begin this? Oh, it's fine. So, I'll stop this after we reach this one. Let's see, wait a second. I'll stop this when we reach 50th. So, that would be the timer. So, we can't turn this on because this is redundant right now. Flow duration, let's make it, how many minutes are done? 8 minutes are done. So, let's make it 40. There is no 40, let us 45. So, it's fine, we turn this on. So, let this be on so that we have an accurate estimate of how much time we are spending on each section and also for breaks. Next, coming to where were we? Yeah, key nutrients. So, we were in lipids. Triglycerides and fatty acids are transferred across membrane or synthesized in fetus. Cholesterol is transferred via active transport. So, triglyceride, fatty acid transferred across the membrane or synthesized. So, it is completely variable. Cholesterol is transferred via active transport. So, this is a key mechanism for cholesterol. Next, coming to amino acids. So, these are transferred via active metabolism, active transport. So, ATP is being used. Amino acid levels are higher in the fetal blood, more in the fetal blood than maternal blood. Similar is the case with the excretory compounds that I mentioned. So, uric acid, uric acid, similar thing being followed. So, volume is less. So, automatically whenever something increases in number, its concentration drastically increases because how small the fetus is compared to the mother. Water and electrolytes, sodium, potassium and chloride cross via simple diffusion, via calcium, phosphorus and iron cross via active transport. So, this one is obvious. So, it is mainly the concentration gradient. Vitamins, water soluble vitamins cross via active transport, while fat soluble are transferred slowly. So, fat soluble, as you may recall, those are, even the membrane mostly is made up of fat. So, it is mainly hydrophobic. So, these hydrophobic substances which are even fat soluble molecules, those are transferred like very slowly, but through the membrane. Those do not require any kind of proteins or anything, but these specific things, these require a protein carrier and also ATP, because the way the this gradient works. What is it? The gradient. Why? Because on the fetal side, since the volume is so less, the concentration is very high even of these proteins. So, these require active transport to transport from the maternal to fetal side. Coming to hormones, insulin, adrenal steroids and thyroid hormones cross the placenta slowly. So, these things cross the placenta, but they do slowly. Adrenal steroids, insulin and thyroid. But these things, parathormone and calcitonin, do not cross the placenta. Next, coming to endocrine function. The placenta acts as an endocrine gland, producing both steroid, fat related and peptide. So, fat derived, protein derived hormones to support the pregnancy. So, which are the different hormones? First one is HCG, second one HPL, third one estrogens and progesterone. Next one relaxin, next one placental enzymes. First one HCG maintains corpus luteum. So, corpus luteum, as you may know, is initially it is very important to maintain the pregnancy. So, what does this HCG help in is maintaining this corpus luteum to maintain the initial part of the pregnancy. Human placental lactogen modulates maternal metabolism to favor fetal nutrient supply. So, this helps in this. Also, it also supports the lactatory function of the female, of the pregnant mother. Next, coming to estrogens and progesterone, essential for maintaining pregnancy and preparing maternal tissues for labor. So, this is, as you all know, this is required even in normal females. So, in this particular case, overall to maintain the pregnancy and to support the labor. Next, coming to relaxin, as the name suggests, relaxes or softens the cervix and pelvic ligaments for labor. Coming to placental enzymes, includes these enzymes: diamino oxidase, oxytocinase, phospholipase A2. So, first one degrades histamines. Diamino oxidase degrades histamines. Oxytocinase neutralizes oxytocin. So, it is there in the name. Phospholipase A2 involved in prostaglandin synthesis. Next, coming to barrier function. So, this is not the other barrier function. This is a different one in placenta. So, placenta serves as a protective barrier, shielding fetus from harmful substances and maternal circulation. So, just like there is blood testis barrier, blood brain barrier, there is placenta forms a barrier for the fetus. So, what does it help in? Selective permeability, pathogen protection and drug transfer. Substances with molecular weight over 500 Daltons are generally restricted, though exceptions exist. So, certain drugs and antibodies can cross, but the most of them which are higher than 500 Dalton do not cross. Pathogen protection. Some viruses though can pass through, but generally they can't infect. So, which are the ones that can pass through? We need to know the exceptions because of the torch phenomenon. So, rubella, CMV, treponema pallidum and protozoa like Toxoplasma gondii can cross the placenta. Next, coming to drug transfer, most drugs used in pregnancy can cross the placental barrier and may adversely affect the fetal development. So, we know so many drugs which are teratogenic in nature and they have a section somewhere over here. So, we will be going through those also. Next, coming to the last function, which is immunological function. Placenta plays a crucial role in protecting the fetus from maternal immune responses while allowing the transfer of beneficial antibodies. So, protecting the fetus from maternal immune responses. So, maternal side, there are so many things going on and the child needs to be protected, the fetus needs to be protected, and while the child needs to be protected from the bad immunological environment, the good immunological environment should support the fetus. So, here we can see the functions. Immunosuppressive properties, placental hormones like EPF and PPA. EPF, early pregnancy factor, and PPA have immunosuppressive effects. Next, coming to HLA expression. So HLA, as we all know, is expressed everywhere all throughout the body, but in this particular case, villus trophoblasts do not express HLA class 1 or class 2, reducing the risk of maternal immune rejection altogether. Extravillus trophoblasts express HLA class 1 molecules, allowing controlled immune interaction. So HLA wise, we are secure. So you might be knowing from pathology how immune functions work and how they are dependent on HLA class 1 and HLA class 2, how the cytotoxic T cells are dependent on class 1 and other cells are dependent on class 2, and how antigen presenting cells and all of those work, and entirely everything. If I miss something, please correct me, but overall about the detail specific, but overall it is HLA which is mainly responsible for the immunological function. Next, coming to maternal immune adaptation. Pregnancy induces a shift from, sorry about this again, cell mediated, that is T helper 1 to humoral T helper 2 immunity, which support the fetal tolerance. So it is cell mediated to humoral type, which supports the fetal tolerance. Next, coming to natural killer cell interaction. Decidual natural killer cells interact with HLA class 1 molecules on the extravillus trophoblast, regulating their invasion into the maternal tissue. This interaction helps convert maternal spiral arteries into low resistant high conduction uteroplacental vessels. So you can see how the immune function of these particular cells help supporting the pregnancy altogether. So this thing happens, what? Spiral arteries turn from low resistance into high conductance, turn from high resistance into low resistance high conductance uteroplacental vessels. Next, coming to blocking antibodies. The maternal immune system produces antibodies against trophoblast lymphocyte cross-reactive antigen, preventing fetal rejection. So let us look at the name trophoblast lymphocyte cross-reactive antigen. So overall it is against this particular antigen. So this particular antigen is bad for the fetus, and that's how it protects the fetus. And with that, we come to the end of discussion on the functions of placenta. Now I drink some water. Next, coming to the maternal physiological and cardiological changes during pregnancy, which include the cardiologic and hematological changes, both of which are very important. The rest of them are important too, but exam perspective, these both are very important. Coming to overview of what it entails. Pregnancy induces significant hematological, cardiological changes to support the growing fetus, prepare the maternal body for labor and delivery. So maternal body acts like a different thing altogether during pregnancy. So we need to make sure that it is ready. So we have different changes that take place. So these changes ensure adequate oxygenation, number 1, nutrient transport, number 2, and waste elimination, number 3. So we have already seen the functions of placenta, and these maternal changes help support that. So overall, that is the main link between. So we all know that is the main link between the maternal and the fetal side. So supporting the functions of the placenta forms the main basis of maternal changes, while protecting the mother against excessive blood loss during pregnancy, during the childbirth. So this also forms an additional function of these maternal changes. Coming to the hematological changes, there are few of them like blood volume change, plasma volume change, red cells and hemoglobin, these change, and overall what is the advantages of this thing. This is a separate discussion comparing how the change helps, and then finally we talk about leukocyte change. Then there is also this one, what is it, plasma protein change and blood coagulation factor change. So overall, though this might look just about the volume, so whenever in clinics you might just hear hemodilution everywhere, but there are a lot more things which are going on. So even when I was going through, as I was scrolling, you might have realized even I was just thinking about hemodilution, but there are many more things. There is blood volume, plasma volume, red cells and hemoglobin, and then this is separate section. It shouldn't be D actually, it should come under separately how this entire thing helps, but that is also a heading. Then you have leukocytes and immune system this one changes, and plasma protein change, finally blood coagulation change. So these form the hematological change. Hematological meaning blood changes. So first one being blood volume. Blood volume increases markedly during pregnancy, beginning around 6th week, peaking around 30 to 34 weeks. So we will just see this one, pregnancy weeks. So I want this thing, a very nice, it is not available. So let us see if there is a chart. It is not available. I needed something, maybe this one would work. Yeah. So over here you can see, what is it? It starts around 6 weeks and peaking at around 30 to 34 weeks. So starts from 6 weeks, 6 weeks starts from here and increases till here. And what is the number? 6th week to 30 to 34 weeks. So 30 to 34, almost third trimester. So it keeps increasing. By term, volume, blood volume increases by 30 to 40%. So 30 to 34 is there. So remove the 3 and add 1 0. So 30 to 40%. So that is in numbers 4000 ml to 5500 ml. So 6th week to 30 to 34 weeks, that is approximate increase in 30 to 40% of the volume. Blood volume. The increase in blood volume accommodates the vascularity of enlarging uterus and supports the uteroplacental circulation. So fetus is also there, the placenta is also there, the uterus is there, everything demands more blood. So this change supports that. Next, coming to plasma volume. Plasma volume rises parallel to blood volume with increase of 40 to 50%. So it was 30 to 40%, here 40 to 50% by term, reaching an increment of 1250 ml. 1250 ml. Total plasma volume increases by about 3.75 liter. 3.75 liter. This increase is pronounced in multiple pregnancies and in case of larger fetuses. So this one is more pronounced, meaning you can see it more clearly in multiple pregnancies and large fetuses. So 40 to 50%, 1250 ml increase by 3.75 liter. Red blood cell hemoglobin, red blood cell and hemoglobin RBC mass increases by 20 to 30%. So 1400 to 1750 ml. So we were from 30 to 40%, 40 to 50%, here it is 20 to 30%, an increment of about 350 ml. Total hemoglobin increases by 18 to 20 ml, 18 to 20%. So here at 20 to 30, here it is 18 to 20%, from 475 grams to 560 grams. So percentage wise 18 to 20% with a rise of about 85 grams. Despite the increase in RBC mass, the hematocrit decreases 38 to 32% due to disproportionate rise in the plasma volume. So this RBC cell mass increase cannot keep up with the plasma volume increase. So plasma volume increase is how big? 40 to 50%, but this one is 18 to 20%. So there is a difference. If there was a complete matching, then it would have helped, but in this particular case there is physiological anemia because of the disproportionate rise in the plasma volume. So how much the hematocrit decreased by 38 to 32%, 38 to 32%, 32 in normal state, 32 in pregnant state. Advantage of relative hemodilution. So we are talking about hemodilution, which is everybody talks about. Reduces blood viscosity, optimizing gas exchange, protects against adverse effects of posture and exertion, minimizes the risk of maternal blood loss during pregnancy. So overall you have lot of volume with which you can entertain a lot more blood loss during the delivery. But if you had less of hemodilution, that would mean less of volume. So you couldn't lose a lot of volume during the delivery. But in this particular case, since there is hemodilution, you can lose so you can increase quite a lot more. Maybe that's the right way of saying it. I'm not particular, but you get the point. You can lose a bit more. Yeah, that's the way. You can lose a bit more volume, and protects the adverse effects of posture and exertion and blood viscosity. So this one, in this particular case, one is, I think it is mainly about this thing, the coagulatory system. That is what I am thinking about, but in this particular case it is here they are optimizing gas exchange. Coming to leukocytes and immune system. Neutrophil leukocytosis with count rising to 8,000 mm3, potentially up to 20,000 in labor. So neutrophil rise to 8K and 20K in labor. This rise is due to increased estrogen and cortisol levels. Estrogen and cortisol levels, enhancing both humoral and innate immune responses. Estrogen and cortisol levels, they are the main thing that is responsible for this, and enhancing humoral and innate immune responses. Plasma proteins, total plasma proteins increase from 180 gram to 230 gram, 180 gram to 230 gram. Plasma proteins concentration decrease from, because of hemodilution, 7 gram per 100 ml to 6 gram per 100 ml, 7 gram per deciliter to 6 gram per deciliter. Albumin drops by 30%. 30%, can you imagine? No, you can't. While globulin levels show a slight increase. So globulins increase, albumin decrease. So overall AG ratio, albumin globulin ratio, decreases from 1.7:1 to 1:1. So with this you can imagine what you can see in the pregnant female. You can see edema. Next, coming to blood coagulation factors. It is a hypercoagulable state. So why is it required? So at the end of pregnancy, you might know the PPH risk is quite high, meaning PPH is a thing we need to worry about. So what helps reduce the PPH? The increased coagulation that is present. So that is how I think about it, why it is hypercoagulable. Fibrinogen increases by 50%. I am not looking at these numbers, I am tired of the numbers. Fibrinogen starts from Fi, 50 starts from Fi. ESR markedly rises markedly, 10 to 40. Platelet count shows conflicting but may reduce by 15%. Fibrinolytic activity is decreased. This can remember since it is coagulable, hypercoagulable state. While clotting time remains unaffected. These changes enhances hemostasis during delivery. So hemostasis, meaning as I mentioned earlier, you don't want to lose a lot of blood. So what do you need? You need to clot the blood whenever you start losing it, but increases the risk of thromboembolic events. But since there is an upside during delivery, there is a downside throughout the pregnancy. Coming to the next one, which is CVS changes. There is anatomical change, and you can see the clinical findings, and then we speak about the physiology, which is cardiac output, blood pressure, venous pressure, and a pathology. Like I'm not particularly sure whether you should call it a pathology, but fine. It is supine hypotension syndrome. And finally, we look at the hemodynamics, how the blood flow changes. So that is what hemodynamic means, the changes in blood flow. Next, coming to the anatomical changes, heart is placed upwards and slightly to the left due to enlarging uterus. So the uterus grows, it pushes the heart slightly to the left. See, it's already in the left, so exaggerate that thing. So more upward and rotated to the left. The apex beat shifts to the fourth intercostal space. approximately 2.5 centimeter outside the midline. So let's look at some diagram, because we are tired of looking at the words. So we can look at apex beat. So apex beat, usually it is this region. Let's see some nice image. So somewhere near the nipple, and this is 5th intercostal space, but in pregnancy it is pushed up, it goes into 4th intercostal space and more laterally towards the left, the rotation. Next, coming to the clinical findings. Systolic murmurs are due to increased blood flow and decreased viscosity. So where else do you hear systolic murmurs? In case of anemia, and anemia can predispose to high output cardiac failure. So you are pushing, not enough blood, pushing, not enough blood. So that is what it is, systolic murmurs. You are pushing and there are a lot of blood going on and decreased viscosity, but will it help? Sometimes it does, sometimes it doesn't, and that leads to anemia in pregnancy. A continuous humming murmur may be heard over the tricuspid area and left sternal border. So there is the left sternal border. There you can hear a continuous humming murmur, tricuspid area and left sternal border. Then there is ECG showing left axis deviation. So this thing changes. What is it? The position of the heart changes, and because of that, axis deviation also occurs. While Doppler echocardiography reveals increased ventricular dimensions. Doppler echocardiography, using that we can look at increased ventricular dimensions. Why? Because there is a lot of blood which is being pumped, and this seems to be a compensatory feature. It's coming to cardiac output. Cardiac output increases by 30 to 50%. 30 to 50% starting from 4th week, 6th week, peaking to about 30 to 34 weeks. Where else did we see this number? We saw this number here, starting from 6th week, peaking to about 30 to 34 weeks, which is blood volume. So number 1 over there, here it is cardiac output, and the numbers 4.5 liter to 6.26. I am not particularly sure how hard would it be to remember all of these extra numbers. So all this content is directly from Datta, and Datta, as you all know, has so much of information which is hard to comprehend as a first time reader. So same thing was the case with me. So this thing actually helps, particularly in case of Datta, but it is not directly copy pasting. It is a proper way where you can actually understand what's going on. But Datta is good in case you want to actually spend a lot more time in looking at it, trying to understand, and it will stick much more easier compared to if you are just reading through this. But if you supplement this, reading this along with the other things like Google, ChatGPT, my voice, you might remember things much easily. Next, coming to during labor, cardiac output. Yeah, we missed this point, sorry. The rise is primarily due to increase in stroke volume 27% and heart rate, which is 17%. Stroke volume is 27, heart rate 17. During labor, cardiac output further increases by 50%. So cardiac output initially was 30 to 50%, and now it is 50% more, with an additional 70% immediately postpartum due to autotransfusion from uterine contraction. The uterus is filled with blood, and now even the uterus is becoming small, and all the blood is coming back into the systemic circulation, and cardiac output is rising to 70%. So initially it was 30 to 50% rise, then further by 50% rise, then additionally 70% rise, which is very, very interesting and very helpful to understand. Next, coming to blood pressure, systemic vascular resistance decreases by 21% due to vasodilatory effects of progesterone and nitric oxide and prostaglandins. So these are the mediators: progesterone, nitric oxide and prostaglandins. This leads to 5 to 10 millimeters of mercury drop in diastolic and MAP. Diastolic is dependent on total peripheral resistance, and mean arterial pressure is dependent on both systolic and diastolic, but since there is a drop in diastolic, mean also drops. So, since it's a mean, it's mean, right? So, mean means somewhere in the middle. So, the middle also drops since the bottom one drops. With partial normalization near term. So, SVR reduces by 21% and this translates to 5 to 10 mmHg drop in mean arterial pressure. Venous pressure. Femoral venous pressure increases significantly in late pregnancy due to uterine compression of common iliac veins. So, uterus compresses the common iliac veins, and because of that femoral venous pressure. So, femoral veins and common iliac. So, you can see how there is common iliac and femoral, and here there is uterus. So, uterus is here and pressure over here increases because this is getting blocked. It is very simple. Since it was an anatomy thing, it was much easier to show on the screen. Venous pressure may rise from 10 centimeter of water to 20 to 25 centimeters of water, contributing to physiological edema, varicose veins and hemorrhoids. So, these are all the venous issues: physiological edema, varicose veins and hemorrhoids. Then finally, there is supine hypotension syndrome, wherein whenever the patient lies in supine position, inferior vena cava is blocked, leading to hypotension, tachycardia and syncope. Tachycardia is a compensatory mechanism for decrease in BP, because the blood flow to the, let us see, superior vena, supine, not superior. Let us copy this. This is much easier. Superior. So, the words get confusing. Supine hypotension. So, here you can see how the mother is lying down and the uterus is compressing the IVC, and because of that less blood is going to the heart, and because of that there is hypotension, and tachycardia being a compensatory mechanism, and syncope because less blood is going to the brain. This is elevated by turning the patient to the left lateral position. The uterus is no longer compressing the IVC. Next, coming to the hemodynamic, the blood flow changes. One is the regional blood flow. Uterine blood flow increases from 50 ml per minute to 750 ml per minute. I don't like this thing. Yeah, 50 ml per minute to 750 ml per minute, accounting for 15% of the total cardiac output. 50 to 750. Renal blood flow 400 ml at 16 weeks and maintaining at this level until term. Pulmonary blood flow increases by 2500 ml per minute. 2500. How much? 2500. Skin and mucous membrane circulation increases, reaching 500 ml per minute, 36 weeks, contributing to heat sensation and sweating. So, again uterine blood flow 50 to 750. Renal blood flow increases from 400, increases by about 400 ml. So, that is there. Pulmonary flow rises by 2500 ml. Skin and mucous membrane circulation increases, reaching 500 ml by 36 weeks. So, I am not shouting again. It was not actually shouting. I spoke. I am not particularly sure whether you can change you can hear the change in the voice volume. Anyways, and you can't even see my face too. So, this might become a little boring. I can feel the boredom from here itself. At least I could have seen myself through the camera, but I can't right now. But it is fine. colloid osmotic pressure decreases from 20 to 18, so contributing to fluid shift and edema. So we have already seen how plasma proteins change. They are this thing 7 gram. So you can see Ag ratio from 7:7:1, 1.7:1 to 1:1. So overall cardiac output changes by 40%. So 27 and 17. So 27 by stroke volume, 17 by heart rate. Yeah, right. 27 by stroke volume, 17 by heart rate. Yes. Then there is it is here itself. Sorry about that. Yeah, venous pressure doubles because of how heavy the uterus is. Systemic vascular resistance decreased by 21%, pulmonary vascular resistance decreased by 34%, colloid osmotic pressure decreased by 14%. So with that we end the discussion on maternal physiological changes during pregnancy. Next comes diagnosis of pregnancy in the first trimester. So let's see what do we have here. So it's a subjective symptoms. So we have some subjective symptoms, then we have signs. We have some named signs too, which I personally found very difficult to remember earlier, but with time, as we repeat the names over and over again, it becomes easier. And that is what is more important. Keep repeating the names and try to imagine what the names mean. This directly just before the exams won't help. Let me drink some water. Coming to diagnosis of pregnancy in first trimester is based on combination of subjective symptoms, objective signs and lab investigations. Early and accurate detection is essential for initiating appropriate prenatal care and identifying any potential complications. So subjective symptoms, which are the presumptive signs. So from the maternal side, what does she complain with? What does she feel? What does she experience? 3 different words are often first indicators of pregnancy. They are not definitive as they can occur in other conditions too. So non-definitive. First one being amenorrhea, most common sign, earliest sign characterized by absence of menstruation in a woman of reproductive age. So it is self-explanatory. In pregnancy, amenorrhea occurs due to fusion of decidua vera with decidua capsularis. So let's see how those look like. So you can see decidua vera is over here, decidua capsularis is over here, and it seems like both of these fuse, leading to amenorrhea. That forms the basis of prevention of menstrual shedding. So because of fusion, cyclical bleeding may persist up to 12 weeks, but it is usually scanty and shorter than normal period, which is termed as placental sign. So this is amenorrhea. And what do you do the first time a woman of reproductive age group comes to you with abdominal pain and amenorrhea? You think of pregnancy. Next, coming to morning sickness, nausea and vomiting affects about 70% of the pregnancies, more common in primigravida, appears soon after missed period and usually subsided by 16 weeks, but it can occur later down the line too, and varies from mild nausea to severe vomiting, but rarely affects maternal health. So a lot of vomiting may be seen in twin pregnancies. Frequency of micturition common between 8 to 12 weeks due to uterine pressure on the bladder, increased bladder mucosa congestion and changes in maternal osmoregulation. So maternal osmoregulation can affect this, and also increased pressure on the bladder by the uterus and increased bladder mucosa congestion typically subsides as the uterus rises out of pelvis after the 12th week. So it is 8 to 12th week. Next, coming to breast discomfort, a feeling of fullness or pricking sensation may be noticed as early as 6 to 8 weeks. So 8 to 12 weeks, just before the 6 to 8 weeks, especially in primi. Fatigue, generalized tiredness is commonly and early symptoms due to hormonal changes. So with that we finish the symptoms. Next, coming to signs, objective signs. So these are done during physical examination and provide stronger evidence. So breast changes, per abdomen changes, pelvic changes, vaginal changes, cervical changes, uterine changes, and there is a Palmer's sign. Coming to breast changes, enlargement with vascular engorgement, evident. Sorry about this. I'm not sure, maybe doing this. Maybe I need to stop doing this. I'll just hold the cursor here, that would be easier. Just observe the cursor carefully. Yeah, enlargement with venous engorgement becomes evident by 6 to 8 weeks. So breast changes, vascular engorgement 6 to 8 weeks. Primary areola darkens and Montgomery tubercles becomes prominent. Montgomery tubercles, should I? Yeah, it's fine. Montgomery tubercles. So here you can see the areola might darken and Montgomery tubercles might start appearing, and colostrum secretion may occur as early as 12 weeks. 12 weeks, first trimester, colostrum, per abdomen, uterus becomes pelvic organ until it remains pelvic organ until 12th week and may be palpated as suprapubic bulge. So above the bladder, suprapubic bulge. Next, coming to pelvic change. So you might know in the examination how you measure the uterus size and all that, longitudinal length and horizontal length. Pelvic changes, there is something called as Jacquemus or Chadwick sign. So all these, bluish discoloration of vaginal wall due to increased vascularity. So let's see this. Let's see this in this one. A bluish or violet discoloration of cervix and vaginal walls. So I just wanted to make sure that what I have written is correct. You can see bluish discoloration, that is Chadwick sign, Jacquemus or Chadwick sign. Next, vaginal sign, bluish discoloration of the antevaginal wall, softened walls and copious non-irritating mucoid discharge appear by 6th week. Softened walls and copious non-irritating mucoid discharge. So we spoke about bluish walls, bluish discoloration of the walls, and bluish discoloration of anterior vaginal wall. Next, coming to increased pulsation in lateral fornices. Which is Oscienter's sign by 8th week. Next is cervical sign, which is Goodell's sign, softening of cervix as early as 6th week. Goodell's sign, and 6th week starts from G when this looks like G. Softening of cervix. Cervix appears bluish on speculum examination, so everything is blue. That is Goodell's sign. Even if you remove this part from G, it looks like C. So Goodell's equals cervix. Not sure if you can imagine G. G is here. G. So G, if you remove this from G, it looks like C, like that. But it's fine. Uterine signs. Shape, size, consistency. The uterus enlarges to the size of hen's egg by 6th week and fetal head by 12th week. Hen's egg by 6th, fetal head by 12th. And Pisca's egg sign, asymmetrical uterine enlargement if implantation is lateral. Hagar's sign, asymmetrical enlargement if implantation is lateral. Next is Hagar's sign, softening of lower uterine segment detectable between 6 to 10 weeks. Softening of lower uterine segment. Next is Palmer's sign, regular rhythmic uterine contraction elicited during bimanual examination, noticeable as early as 4 to 6 weeks. So, I think I should be taking a break because we started quite early, and with this I think I will stop this thing for now.